Fantastic.
So thank you everybody for this opportunity to present to you here today and to get some of your thoughts and opinions on pieces of work that we are undertaking. So the first is a project looking at how trainees learn to prescribe and specifically putting them in the driving seat. Okay, Claire, thanks. Next slide.
Okay.
So just to give you some kind of statistics to start off with. So annually then in the NHS, we've got over 230 million medication errors, and about 60 million of these are considered clinically significant. In terms of deaths, we have about 1,700 up to 22,000 deaths as well from medication errors, and the larger figure encompasses adverse drug reactions as well. Next slide. So if we compare that to some other industries and common things that we do every day, so transport safety. So in 2023, there were 1,600 deaths from road traffic accidents, 13 from motorcycle accidents, 87 from bicycle accidents, and 11 deaths from aviation accidents in the UK. So these figures are much, much smaller than actually what happens within our NHS hospitals. And for my mother, who is terrified of flying, I often do tell her you're safer in an aeroplane than you are in an NHS hospital. So next slide. So what do all of these forms of transport have in common? And they are, so if we click, supervised experiential learning, whether it be on the road or in the air. So if we click, whether it's learning to ride a bike and we've got our parents or grandparents around us stabilising us and having stabilisers on our bike, we are supervised, and we'll have our proficiency in school as well on our bike. Learning to drive, I think we click there. We may remember Maureen Rees from driving school in the late 90s there. We all, if we learn to drive, have to actually sit behind the wheel of the car, whether that's a dual operated car with a driving instructor or with our partner, husband, mother, father by our sides, helping us along the way. And then in aviation as well, so airline pilots, so they will learn to fly both in simulated settings, but also they do have to have supervised flying hours. And if we compare that then to what happens in healthcare with our prescribers in healthcare. So next slide. So some of you may be familiar with this gentleman. So this is Dr. Max Pemberton. She often writes columns in newspapers, and back in the early 2000s, he actually published his diary from when he was a junior doctor. And here we have an excerpt about his third day as a junior doctor, where he was absolutely horrified. Patients' relatives are standing around him. Nurses stating that the patient had a headache, and they're like, please do something. His pen is hovering over the drug chart. He's breaking out in a sweat. He doesn't know how to prescribe paracetamol. He admits his mum, not today's medical training, could successfully give somebody paracetamol. He knows how it works. He knows all the pharmacology behind it, but how to actually write the prescription, the dose, what to write where, how often should be given, it's not something they teach in medical school. And the nurse looks down at him and tells him 1 gram QDS 4 times a day. So in summary, medical school didn't prepare him for life on the wards. It pumped his head full of facts and figures, but it didn't tell him the day-to-day running of the ward, where to find x-rays, how to fill out blood forms, and indeed how to prescribe drugs. So next slide. So we do push our trainees into the deep end, and prescribing skills now have extended from the days of Max Pemberton's junior doctor years to include, we now have final year medical students, foundation pharmacists from 2025, and our non-medical prescribers in training all have to demonstrate that they can prescribe during their training courses. Next slide. So what are we going to do? Push them into the deep end, or actually are we going to have opportunities for them to be learner prescribers? So what we are proposing is to present a pre-prescribing policy, which will allow our learner prescribers to develop the prescribing skills and competence in the real world by prescribing under the direct observation of your qualified prescriber. And this kind of supervised prescribing, this learner prescriber, we're terming pre-prescribing. So pre-prescribing has been carried out elsewhere. So in Ireland, they have a national policy on pre-prescribing. It's also been done in parts of England and Scotland as well. And what they've found is where you do have a robust pre-prescribing policy and procedure, then there's no risk of patient harm. Indeed, the evaluations that they've done have shown that the pre-prescribed prescriptions are 95 to 90% accurate, and the errors that are often made then were ones that didn't lead to any patient safety risk at all. So they were maybe a route of administration, a missing start date, a spelling mistake, or multiple routes. And some of these errors nowadays would be eliminated by the use of electronic prescribing systems as well, because routes are mandated, start dates, etc., are mandated as well. So next slide. So the pre-prescribing, just to clearly define it, is when eligible trainees, so our medical students, our foundation trainee pharmacists, and our healthcare professionals who are undertaking accredited non-medical prescribing qualifications. It's where they then write these authentic prescriptions for real patients under the supervision of a licensed prescriber who reviews that prescription, signs the prescription to authorise administration, but provides feedback to the trainee as well, so that they can learn how to prescribe, and noting good practice, but also if there are any room for improvement. So the importance of pre-prescribing, so the aim then is to develop real-world capabilities. It integrates the pharmaceutical knowledge, which Max Pemberton clearly in his quote there indicated he had been taught at university, but it integrates that with the system and the social factors of working in the clinical setting, which simulated prescribing doesn't really replicate. It provides an enhanced learning experience. It's linking that theory to real patients. It contextualizes and consolidates that learning, but also it improves patient safety in the long run as well, because when these trainees become qualified prescribers, they're already equipped with those skills of prescribing because they've had that supported environment beforehand to acquire those skills in a fail-safe environment. And next slide. So our always pre-prescribing policy aims to provide a governance framework to support the pre-prescribing across healthcare organisations. So it clearly would define what trainees could undertake pre-prescribing, their roles and responsibilities. It will outline the criteria for supervisors as well, their roles and responsibilities, so that they're fully aware that the clinical responsibility for that prescription does lie with them, as they are the ones that are signing that prescription at the end of the day after checking what the trainee has done. So there would be a standard operating procedure there for pre-prescribing, so they would all be undertaking the pre-prescribing task in the same manner according to the standard operating procedures. And also there would be monitoring and evaluation set up as well to ensure that we are fully aware of how successful the project is, and if there are any concerns, that these then can be escalated. So we do have a pathway in this proposed policy. So what activities that must be undertaken by the trainee, the educational supervisor, as well as any delegated clinical supervisors in the ward. So obviously we have defined roles there. So the educational supervisor, often for non-medical prescribers, the termed designated prescribing practitioners, but they are the prescribers or that have the overall responsibility for overseeing, supporting and assessing competence. and they will work then with academic partners, trainees, to take this pre-prescribing during the period of learning and practice. But it may be that the supervisor isn't always on the ward or in the clinic, and therefore they can delegate the supervision of pre-prescribing to a delegated clinical supervisor. So they have to be authorised by the educational supervisor or the DPP then to observe that pre-prescribing and countersign the prescriptions. So the pathway has outlined activities that each of those personnel have to undertake before pre-prescribing happens. It involves completing mandatory training, reviewing the standard operating procedures so that they're familiar with it, and there must be a learning agreement contract completed as well, so that the trainee, the supervisor, and the delegated clinical supervisors know exactly what medicines can be prescribed, and there can be restrictions placed as well on what the trainees can prescribe, and who is eligible to supervise. And also they would know then they would have to sign that they would be following those procedures. Then there would be the pre-prescribing activities, so that would be undertaken in the clinical setting according to the standard operating procedure with prescriptions annotated, so that it would be evident to nursing staff and pharmacy staff reviewing those prescriptions that those medicines have been pre-prescribed. The pre-prescribing has to occur under the direct observation of the delegated supervisor, so they are there right by the side of the trainee, and they then check everything and correct everything, or correct if there are any mistakes, and then sign the prescription, taking full responsibility for it. And they must feed back to the trainee as well. Then at the point of administration or supplying the medicine, the nurses and pharmacy staff should be able to identify the prescription has been pre-prescribed. If they've got any concerns, then they shouldn't administer or supply the medicine. They should escalate the concern straight away back to the delegated clinical supervisor so that it can be rectified. And if they do identify any errors as well, there is an escalation process which they must follow. And then there's the overall review of the whole pre-prescribing policy process as well. So the trainee will have regular meetings with the educational supervisor where their competence would be assessed based on reflection of the pre-prescribing in practice, and the educational supervisors then would be required not only to deem whether the trainee is competent to undertake further pre-prescribing and to continue with pre-prescribing tasks, they would also be reporting any concerns as well to relevant partners. And next slide, I think we have the escalation pathway. So types of concerns that we may see, hopefully not, but may see, but there may be fitness to practice concerns. So there's an escalation pathway for each of the different trainees for those fitness to practice concerns. Likewise, if there's a medication error or a breach of a standard operating procedure, then there's an escalation pathway that to be followed in terms of reporting that incident to both the organisation, but also to the trainees, supervisors, educational supervisors, employers as well, and universities where relevant, so that there can be monitoring and of the actual process as well, and that any concerns can be identified, rectified immediately, preventing any issues for patients. And I think that comes to the end of that. So yeah, it's opening it up to conversation really, to see if there is any concerns from a patient perspective around this potential practice, whether one thing that we have thought about, where I actually came here to seek your views on, whether if you as a patient, would you want to be able to consent to that process, to the medical students actually pre-prescribing a medicine for you? So that's something that can be added in as part of that governance